So let's move to the question that I have as the top one. Um, how does this compare to remote technology to general population in Australia? Imagine that, you know, the question is really asking, how does the use of remote technology with our population of refugees and asylum seekers to compare with the use of remote technology with the general population in Australia? Maxine, do you want to have a go at that one first?
Well, I can tell you how many people use technology in Australia, but I couldn't make that distinction. But something like 86.5% of the population has access to the internet, according to, I think, 2019 figures in Australia. So whether it's by phone or computer, and almost 18 million people, and I think that's about 2017 or 18, had smartphones as opposed to any other kind of mobile device. So I'm not sure I'm answering your question, but there's an awful lot of people using an awful lot of technology, whoever they are.
Catherine, would you like to have a go at this?
Sure, yeah. I think that COVID kind of thrust us all as counsellors into working remotely when it was typically the default to go face-to-face. So it was very much a challenge, I think, for both our counsellors and our clients. And I think that some adapted differently. Some clients actually, I'll speak positively first. Some clients, because of a lot of overwhelming needs, so family needs, other commitments, and even my client Samir, who for him a $4 train ticket was quite an expense. So he actually did prefer that, and it was just made therapy more accessible. So in some ways it was very much a beneficial way, but some other ways that it was a little bit challenging for our clients, like they might not make the difference between using their phones and WhatsApp calls for their family members, which are quite casual and conversational, to the actual therapy that we like to have a special space for therapy. We might use certain things like questionnaires, like the WHO5 and the Harvard Trauma Questionnaire, for example. Bringing those sorts of structures into phone counselling was perhaps a little challenging, and also using interpreters, again, with mixed experiences, but generally it took a little bit of practice, I think, for both the clinicians and for our refugee clients to get used to. But yeah, I think overall, bringing this second option of therapy, or third if you include Zoom, has brought a lot of benefits.
Thank you. Let's go on to the next question, which is, could you please elaborate, and I think this is directed to you, Catherine, a bit on radical acceptance and preparing asylum seekers for the fact that they might be sent back to the country where risk of harm to the physical or psychological well-being is imminent?
Well, that's such a good question. Thank you so much for that. It's so, like I used the word before, diabolical, and it's such a strong word. Like I said, this is from the clinical masterclass years ago, and it stuck with me. And it's kind of all very well for us in our role as therapists to try and help prepare a client who, is at a double negative pathway, potentially being sent back home to a country where they're very likely to face heavy persecution, imprisonment, or being killed. I'm sorry to say, but that is sometimes the reality for a client, especially a client that has converted to Christianity, going back to Iran, and the authorities will be very punitive about that. So what is a term like radical acceptance, and how can that possibly bring some kind of relief? It's a really tricky one, and it's something that has to sort of be worked through, week after week after week, helping the client to have the capacity to embrace something so far out of their control. It's called radical for a reason, it's such a radical thing to think about, or to let alone accept. So conversations with Samir, gently trying to help him prepare, because we don't want a client to have false hope or to be in denial either. That wouldn't actually be therapeutically okay for a client. Like, we have to sometimes face reality, and we hope and hope and hope, as with everything, that when the decision from the Federal Circuit Court will be favourable, but then still has to go back to the AAT, so it's not guaranteed a visa yet. So I think lots of education for the client, very gently, just letting him know like the expectations. And yeah, I think sometimes I would look at the client's coping skills, their religious beliefs. So if my client had like the ability to pray or to trust in a higher purpose, or to use that as a reference point, and many of our clients do, regardless of the religion that they follow, it is such a powerful coping mechanism, especially like, you know, with our Arabic speaking clients, we hear the term inshallah all the time, which is like God willing, you know, so it's very much a way of a good reference point for them. And I think it dovetails nicely with the DBT concept of radical acceptance, but it's certainly not easy. And this is why it's there's no straightforward answer.
Thank you, Catherine. We've got a couple of questions that one I think that you've already addressed, but you might want to emphasize again. If the client hangs up and is not reachable, should we call the police or 000?
Yes. Look, you're right. At the beginning of my presentation, I did say that it's so important that we have emergency contact details for any client, whether they're international or local, doesn't matter. But if somebody hangs up and you can't get hold of them again and you're worried about them, because you should have some details about where they live or a phone number or an email address or all of the above, you absolutely should call 000 if you are worried, definitely.
And the follow-up question, also from John Martin, is how do you assess if there is a secondary gain from the presentation of self-harm or suicidal threat? And is it possible that the client may do so out of a desperate cry for help?
Do you want to start with that, Catherine?
Would you like me to? Yeah. I remember, again, I mentioned Dr. Nick Bendit, who's a psychiatrist at the Centre for Psychotherapy. He spoke about this, and he, with his client work, he actually found that's very, very, like it's lower, much lower on the scale of things in terms of the reasons why people self-harm. Like often it is commonly known out, maybe they're just doing it for attention or, you know what I mean, and for secondary gain purposes and things like that. But from his perspective, he thinks that's quite lower down on the list. There's other really pressing, urgent reasons why this person has acted out in such a way, like maybe like a recent loss of status, loss of assets, feeling trapped, powerless, hopeless, receiving bad news of a loved one, unfavorable verdict. So, I mean, how do we assess? I guess, like I said, there's probably a lot more reasons why this would happen, but we still have to treat it so seriously, and we still have to follow all the right, you know, safety procedures, referring them to COMET, getting a support person. I always touch base with their GP or psychiatrist, and as a professional, we have to document everything and speak with our clinical consultants, supervisors, managers. So I guess in that way, try not to second guess the motive or be too cynical, but just treat every, like, self-harm as extremely serious, and, you know, use our, according to our professional ethics, we have a lot of duties to uphold, if I'm honest with you.
Yeah, I agree, Catherine. We must always, it doesn't really matter what they're doing. The fact is they're doing that, why they're doing it. The fact is, if that's what they're doing, we need to act regardless of whether it's, you know, whatever, as you said, whatever the motive behind it might be.
Thank you. Next question that I'd like to tackle from Nurig is that could either of you speak about any major differences in therapeutic or crisis intervention for asylum seekers compared to the general population? Suppose it can be tackled from both sides.
You want to go first, Catherine? You have vast experience in this area and far more than me.
With asylum seekers? Yeah, sure, that's fine. If you remember the slide that speaks about the complex interaction of stresses, that's got the interacting circles with the normal life cycle, the trauma reactions, and then the challenges of resettlement. What we're facing is a lot of challenges of resettlement, especially the asylum seekers, because yeah, like my client Samir, he had been unresolved in his visa for 7 years and waiting. So it's you're working at this level where nothing's certain, everything's in limbo, and his fate could change like that. So it's a very it's quite at the pointy end of things, I think. And so in terms of therapeutic interventions, he's not fully safe yet, so we don't do deep trauma work. It's not really responsible at that time because he's not safe yet. He's not fully established safety with his visa status established and everything like that. So it's a lot of the supportive counselling that I spoke about, trying to manage his distress with distress tolerance skills, or the compassion focused techniques that I shared about trying to reduce the intensity and the harsh and hostility nature of his voices. So that's some of the therapeutic interventions that I've used that I think is, yeah, we're more acute with asylum seekers. And so it's that working in such an acute situation without a lot of long-term resolution yet, before too much deep trauma therapy is unpacked, and a lot of case management and a lot of patience, because you might be thinking, oh my goodness, I've been trying to establish safety for 6 months and he's still not safe, like he doesn't feel safe. And so it's a lot of patience and a lot of case management and putting in all sorts of supports during this really critical time. Maxine, do you want to speak anything else about the general population?
No, I think succeed.
Maybe we'll throw this one at you, Maxine. What if a client is adamant that they will not go to hospital? If forced, they will suicide. How do we manage the challenge of respecting their fear based in reality of the experience and our responsibility?
So assuming that we're talking about remote technology, we're not physically with them, we have to act according to our professional boundaries and our professional requirements. We have no choice. So it's almost like the difference between dignity of risk and you know, having to do something because you have duty of care. We can't be with them 24/7 to support them, so we have to take action. So if whether it's by phone or internet, it's about we actually have no choice but to report, but to source help. And then what happens after that is actually beyond what we can actually do or intervene with. Catherine, how do you feel about that?
Yeah, I'll just mention that I've had to over the years I've worked at Stats, I've had to call Comet and see like some of my clients' schedule. That happened a number of times. And there's a lot of anxiety about that, I think, as a therapist as well. Sometimes you feel like, oh my goodness, they're going to be hospitalized and we can't control the way that they might be treated or triaged in hospital. I had one male client who was, had a very violent history of torture and trauma, and he was quite at risk. So I had him assessed and he was taken to hospital, and he was actually telling me, oh, it's like jail. I feel so re-traumatized. It's like, and that was a hard thing. But you know what? With the strong rapport that we had, and with the amount that we'd worked together, and with the trust that we developed, he was released from hospital, and he was fine. Like, obviously he was upset that it felt like jail, and it re-traumatized his feelings of being in prison before. But he's a client that I've seen, honestly, 5 or 6 years since that time. So I think if your rapport is strong enough, and they'll really see the depth that you care, even if sometimes the emergency wards at hospital are a little bit unpleasant, but it's something that we have to do.
Thank you. I'd like to throw one about, you both spoke about transference and counter-transference and the issues, in remote. One of the comments that, I've heard often is that in terms of transference, in a way, particularly phone, provides this whole realm, where projections, can be so readily made. And to the extent that, some of our clients, that I've heard of in supervision, sometimes fear actually meeting the counselor face to face once, particularly in this COVID context, once the urge to only communicate remotely is removed. Any comments on that?
Maxine, I'll let you speak first.
Look, I think that with transference, the client is using us as a support. We remind them of someone else, or we remind them of something else in their life, or some authority, or maybe it's not an authority. But I think if we are able to establish a good enough rapport on the phone, if we're able to be very gentle with them, if we're able to build that relationship with them, then they will also be able to see that we are not whatever it is they're projecting onto us. And sometimes being able to then see each other face to face is quite a surprise in a positive way. But otherwise, I think I work exclusively by phone with some people, and I sometimes will challenge, I'm wondering why you're saying that. So I think I said in my slides, I'm often more directive on the phone. So I will actually say, wondering what's behind that. Why are you actually saying that to me? In a way of trying to help them see that perhaps what's happening is a transferential relationship rather than what's really going on from my perspective therapeutically. Catherine?
Yeah, it's a great issue, Jorge. It's just so important for the work that we do. And, you know, I can understand why people may think, or there might be theories out there that say that there is increased transference over the phone, because there's no way you can visualize, or you might just have a vision in your head about the person that you're speaking with, and you might have kinds of thoughts about who they are, what they look like, you know, what house they live in, or anything like that. And so that's definitely an issue. But Maxine has spoken about that, like how with all the experience that she's had, she felt like that's something that can be minimized. I've actually also heard that sometimes if you do have the benefit of face-to-face, it can sometimes intermittently, you know, address or confront or minimize any transference. I mean, because we do have a hybrid way of working at Startts. Since COVID, we have the opportunity of meeting our clients face-to-face. So that's such a different dynamic again. Yeah, and I think that with supervision and just, you know, running everything by our higher consultants or senior colleagues, that we can work through these issues as well. And especially, like I said, issues of powerlessness and injustice. And on the phone, you might even feel more powerless on the phone. But that's where upskilling and consultation can really support our work.
That's right. And you know, something that some clients have sometimes done when I've been working exclusively by phone is they say, "Oh, I've looked you up, and I've got your image. I know what you look like." And it's really interesting that for them that was an important thing to do, and that certainly reduces a lot of the transference potentially anyway. And I have had clients say, "Would you like me to email a photo to you of myself?" And if they offer that, that's fine. It's not something I would ever ask for, but it's really interesting that for some people it's been important to have some sort of visual that they can catch on to. So yeah.
Because of course this applies to counter-transference too, doesn't it?
Absolutely, it does. But again, if we're aware of ourselves and we know very clearly what our boundaries are, we know who we are, we know what we do. I believe this is why I love working particularly by phone, because it really requires you to be alert 100% of the time. You'll be so sharp for all of these things, as well as the actual session content that you're talking about.
Maybe we can move on to, we've got a few more minutes to answer questions. And I got another question that says, what advice would you give for some who would like to work in this type of field in terms of training to support clients?
Seek it out. There's not always a lot of training out there that's specific. However, one of my references is to the Online Therapy Institute. I'm not 1 minute suggesting you go and do any of their courses, but they are a great stepping stone to finding out what might be covered in training that you can then look for more locally based here. Organisations like PACFA, the Psychotherapy and Counselling Federation of Australia, put on regularly webinars about how to work with clients remotely. And I would imagine other peak bodies do the same. So I would suggest looking in those sorts of places for appropriate therapeutically directed training.
Thank you. And Catherine, there's a couple of questions that maybe you can, have a go at. One reads also, what is your role when you attend court with them as a support person? Which we don't do that often, but it's happened on occasion. And the other one, that relates to that is, have either of you had to experience a client being deported?
Yeah. Again, it's not something that we would necessarily do as part of our routine, part of our therapy, but I think with permission from our team leaders and coordinators, it could be a really beneficial thing. I never want to be in the place where I'm the only one that's there to support my client. I would be doing all of us a disservice, ethically and socially. This client needs to be buffeted by a lot of supports. With Samir, I prepared him weeks and weeks and weeks to try to get other people to be there to support him, and unfortunately that just wasn't possible at the time. It was myself and another caseworker, so I kind of felt like there was the two of us to sort of be there present with him. It was at the Federal Circuit Court. It was probably 3.5 hours of hearing evidence, and it's just a judicial review. So if you're familiar with that, it's no new evidence can be brought. So we didn't have to speak or give evidence. We just had to hear the letter of the law being played out to see. So it was a little bit, it was quite an intense experience. And I just think for anyone that does this, just to be really mindful of what's going on inside. Again, talking about countertransference, I had all kinds of feelings of justice or injustice, or I'm sitting here as a psychologist and I'm like, oh, but I can explain this through mental health reasons or whatever. Or yeah, it was a very draining day, to be honest with you. So you have to be really mindful of yourself. Self-care is so important. But I know that Samir really, really appreciated it. He was so grateful for myself and the caseworker just to be present. I learned a huge amount in that time as well to support him further, and actually to support other asylum seekers, because I really could understand more about how the law works, how they really intricately assess each case on its merits. Have I had a client deported? I actually haven't had a client deported that I know of, which sounds strange, but I've had many asylum seekers and some on a double negative pathway, which means that they may have been deported. If I'm honest, I've actually been on maternity leave on 2 occasions with my 2 little ones. So perhaps they might have been deported and I was actually on maternity leave and I didn't have any access to my client files, and I wasn't aware if they were deported. So I know that's a little interesting situation for me to be in. Sometimes we just don't know. Sometimes that's the nature of our work as well. We don't always have closure. So yeah, I don't know if you want to say anything there, Maxine.
Not on that side, but we often don't have anything. We don't have closure with a lot of our clients. They stop working with us for whatever reason, or we don't know what happens next. And particularly on the phone, we have even less of a clue sometimes as to how that might eventuate. So yeah, I just think, like you say, they may or they may not. People may suicide or they may not. We actually don't know beyond the point of our intervention what happens, unless somebody tells us afterwards, which often doesn't happen.
Thank you. We're about to run out of time. There's one last question, which I might just answer very briefly, if you don't mind, which is, how can you help those who have settled here but are desperate to reunite with their loved ones, with family reunion almost stopped with COVID-19 as an excuse and the borders closing, being sold on the injury? Of course, it comes back, I think, to how we support clients in impossible situations. And I'll invite you to comment on that, but also just to assure you that I have been raising that issue with just about every decision maker and politician that we got access to. So have many of my colleagues, both in SISTA services throughout Australia, but also in other, agencies and advocacy bodies and just for every corner. Unfortunately, the priority now seems to be placed on basically, making sure that people don't come from any reason to Australia, even, Australian citizens. But that certainly we see it as one of the most urgent and important issues affecting our clients. Catherine, Maxine, any last word about this before we close the questions?
I guess Jorge's mentioned that this is like conversations that you're having at a very high level of politicians and policy makers. So that's so much out of our control. But in terms of how do I help them, I guess therapeutically, I have conversations with my clients very, very frequently about how helpless they feel, and just saying that, putting it into the room that we are all helpless here. There's a sense of collective anxiety and sadness and fear that the prospect of being reunited with, if you don't even have a permanent visa, is very, very remote. So it's frightening. It's sad. People might have a lot of grief or anticipatory grief if someone might be passing away overseas. So therapeutically, there's a lot to work with there. But yeah, Jorge's already mentioned that there's so much more that is very much out of our hands.
Thank you so much, Maxine, Rosenfeld, Catherine Theodore. It's been a terrific night, and thank you for you very insightful and really knowledge based. I think there's a lot of experience here, and I think we really benefited from a discussion on such a topical issue today.